All right, everybody, here we go. Welcome to Nursing 550, Health in the Community. Today we're going to do a little overview of the first two chapters of the book, the Cup and Curly Population-Based Nursing Concepts and Competencies for Advanced Practice. I want to introduce myself first of all. My name is Aisling Magakin. I am currently working as the Director of Public Health for the Waterbury Municipal Health Department. So the city of Waterbury is where I call home right now in terms of my work. But I used to be faculty, I'm currently an instructor for the University of St. Joseph, and I used to be the graduate clinical coordinator. So a few of you, I think I helped with trying to find locations for your clinical rotations last year when I was still working there. I've been the Director of Health for the City of Waterbury for 1 year in 2 days. I started June 1st of 2021, and honestly, it's my dream job. I feel like it brings together so many of the past positions that I've had. Just a little bit about my background. I have been working as a public health nurse essentially since I got my nursing degree. I've worked in emergency medicine, I've worked in corrections, and I started a nonprofit that lasted a very short while, but it came out of a fellowship that I did with refugees and asylees in Baltimore City, training them as community health workers through the Open Society Institute Community Fellows Program. I also have worked in public health primary settings. So I worked at a HIV, STI clinic. When I was in nursing school, I helped to develop a HIV medication support group. I worked in a women's health clinic at that time as well. And I taught for the for Johns Hopkins School of Nursing for a couple of years in their community health clinical for undergraduate. I worked at the Baltimore County Health Department for a few years as the director or the nursing supervisor, and we had well child clinic, we had immunizations clinic, sexually transmitted infections clinic, one for adults, one for teens. Our office was co-located with the library upstairs, WIC across the street, and the high school behind us. So it was a perfect location for really doing that population-based care. We also had a colposcopy clinic. We did behavioral health and TB in our clinic, but it was mostly family planning, STI, well child immunizations as our kind of bread and butter. After I left there, I moved to Texas and managed the Healthy Texas Babies Initiative, which was the state's response to their high rates of infant mortality and premature birth among African American moms. In particular, it was a statewide initiative focused on all populations, but quickly became a health equity initiative because we recognized that there was a disproportionate burden in a specific community. After that, I was director of community programming in Dallas and East Texas for the March of Dimes. So I oversaw a lot of small grants in that role, and also led a social justice focused Grand Rounds series for healthcare professionals. I left the March of Dimes after a couple of years to go back to the State Department of Health in Texas and served as the maternal and child health clinical specialist nursing consultant. So in that role, I was able to go out and visit Title V funded staff around the state. Title V is the Maternal and Child Health Block Grant from the Health Resources and Services Administration within the Bureau of Maternal and Child Health. So in that role, I was focused on really helping community level staff determine what were appropriate outcomes for them to be working on, and aligning their activities with the Title V expectations and indicators. So we did a lot of work on smoking cessation, vaping prevention, looking at racism as a public health crisis and trying to formulate collective impact kind of responses. We did a lot of car seats, setting up mother-friendly work sites so that mothers could breastfeed, and there were policies in place to breastfeed at work. We also supported development of fetal infant mortality reviews, worked on SIDS prevention, all of those things that kind of fell under the Maternal and Child Health Block Grant. So I moved to Connecticut in late 2019. We moved here in January of 2020, really left Texas in December of 2019 for my husband's work, and I started working at the University of St. Joseph after the pandemic started. So that's sort of an overview of how I got here. I have been working in public health, as I say, since I graduated, and I was really prompted to seek out public health because I was a Peace Corps volunteer in Madagascar for 2 years. As an agroforestry volunteer, I wasn't even doing health as my primary kind of scope of work, but I had applied to do a third year and leave the beekeeping and composting and intensive rice farming and cashew farming that I was doing as my kind of day-to-day work, and work on a project with commercial sex workers in the Northern Capital to sort of equip them with collective impact frameworks to help them organize and get regular healthcare and seek kind of more stable sources of income to complement the work that they were doing. So I, got all set to do that, and then we were evacuated because there was a coup in Madagascar in 2002 after a contested election, presidential election. And I really didn't know what I wanted to do, but I came home, and Johns Hopkins has a fellowship program for Peace Corps volunteers that I applied to that required that you get a bachelor's of nursing, master's of nursing, master's of public health, kind of a 3-year direct entry program for second degree students. So I had an undergraduate degree in English before I went to Peace Corps, and was able to do the accelerated second degree program there, and went straight through for my bachelor's, my master's of nursing in community public health nursing, and a master's of public health. Okay, so that's how I got here. I think that many of you know Dr. Lucinda Canty. She previously taught this course, and so I'm taking over from her. If you know her or know of her, you'll know that these are big shoes to fill. But I think we're going to have some fun with this course. I've changed a couple of the assignments so that they are things that you all can work through independently. I'm not a big fan of group work if you don't have the opportunity to meet in person, and so I've removed one of the group assignments. But I think that what we've replaced it with will will offer plenty of opportunities for you guys to interact via the discussion board and commenting on each other's presentations. So let's dig into today's content. In general, I'm going to post a lecture every 2 weeks because I think that the courses really broken up into 2-week segments. Chapters 1 and chapter 2 really go together, and chapter 3 and chapter 4 certainly go together, talking about epidemiological methods and measures. And so I think it makes sense to arrange the lectures this way. I also feel like there's so much reading in this course, and requirements for discussion, responses, and so forth, that it can make it a little overwhelming if you have a lecture to listen to on top of that. And I want to make sure that you feel like you can get through the content and not be shortchanging the reading because you feel compelled to listen to a lecture. So that said, let's head right in. So to recap, week 1 talked about the reading, and the Curly chapter 1 talked about how the basic sciences of public health provide tools for nurses, advanced practice nurses, to be effective and to develop evidence-based interventions that are utilizing those tools. So those tools being biostatistics and epidemiology, and also, she didn't mention this, but I think it's really critical. My degree as an advanced practice public health nurse, which, just a side note, our certification by the AACN was retired a couple of years after I got it. And so I renewed once, but after the ability to renew by examination was done away with, I haven't renewed since. So that was the degree that I was, or the certification that I was going for. For a while, for 5 years, I was board certified as an advanced practice nurse in public health nursing. But I think it kind of speaks to the state of things in nursing. If you're not doing direct patient care, that there's not as much emphasis on your role. And so those of us that are in population health or working at the population level sometimes feel like the opportunities for us to work as nurses and be recognized for our nursing work are limited, because Connecticut has a requirement for health directors to be MPH certified. Most states require a medical degree, an MD or a DO, to be a director of public health, but Connecticut Connecticut requires an MPH or a physician degree. I'm able to practice as an advanced practice nurse, but using my MPH, I don't need to have a nurse degree to do the job that I do. And yet I think that it really exemplifies the role of an advanced practice nurse in public health and in population health, because every day I look at epidemiological data. Every day I'm assessing the health of this population of our city, which is 114,000 people. And I don't consider one or two of those as individuals. I'm considering the entirety of the population as my patient. And so all of the decision making that I do is based on considering the patient as the community. I think what the text is really trying to convey in this chapter is the importance of that perspective, recognizing that you all are becoming advanced practice nurses in primary care or in psychiatric mental health nursing. That expectation that you're always taking into account the health of the greater community doesn't go away just because you're not necessarily going into an advanced practice role in public health. So that's kind of the seed that I want to plant at the beginning of our discussions. That while I recognize that your role is a primary care role, and it doesn't take anything away from that to say that because you are in advanced practice, that you should always be considering the population in which your patients sit as your larger responsibility. That we, as advanced practice nurses, think about more than one person at a time. We have that capacity because of our advanced training. And our role is to evaluate outcomes in populations, identifying health problems, the needs, the assets of those populations, and then the differences that make those groups unique. So that's why there's such a focus throughout the book, throughout the readings that we'll be providing on health equity and the importance of centering our work in health equity and the key tenets of anti-racist practice. Because the only way that we can really achieve prevention is by examining it from the population level. The other things that are pointed out in the first chapter are the importance of looking at efficacy when we consider interventions and effectiveness. So efficacy, does this intervention work under ideal conditions? Is it something that's been shown to work? Is it evidence-based and effective? Efficacious. So does it work in the laboratory? And then effectiveness, is it able to be translated into the real world? Some other, components of this that they didn't really get into in the chapter, but I think are so relevant, are scalability. Like, are you able to take what you've observed in one patient and successfully replicate it in multiple patients sequentially, and scale that out to a population level intervention so that you can enhance the results that you get at a more global level. So you change your practice based on an article that you read, for example, and you implement that practice several times with patients under your care before you take it to the administration of your hospital or your clinical practice or your clinic, and say, okay, we need to change the way that we do things based on my observations of this consistent outcome, so that everyone practices the same way in our practice and receives the same benefit, achieves the same outcome. Really kind of how you translate the role of population nursing into primary care is how do you make it bigger than you and your one patient. So those are some of the issues that I think that they handled in the first chapter. The health impact pyramid was not necessarily included, but we're going to be using this as a framework in some of the subsequent chapters. So I wanted to introduce it here. Tom Frieden, who, if you followed even a smidgen of the press coverage throughout last year in 2020, Tom Frieden was an often critic of the way that the COVID emergency was managed by the White House, and he is, he's a physician, he's a researcher, he is focused on effective practice and really making sure that things are, how do I say this, based in fact, based in evidence. In 2010, he proposed this framework for public health action, the health impact pyramid, and the link is here. I'll provide you guys with all of the slides so that you can reach these links on your own. But in general, we've always considered a sort of a four-tiered pyramid when we think about the work that we do in public health. And he's proposing a 5-tier pyramid. The top level of that pyramid is our work on counseling and education. The bottom tier of the pyramid is socioeconomic factors, and in between are the various levels. You can see the arrow that goes down diagonally down the side of the pyramid indicates the level of impact. So we end up having a smaller impact when we focus our efforts on counseling and education. For example, we try to tackle obesity by saying, okay, primary care providers, talk to each of your patients about eating healthy and exercising. And you are requiring them to have a lot of number one, self-control, number two, locus of control, ability to change their own behaviors, and so forth. And so you're going to see a smaller impact by virtue of the effort needed being greatest among the recipients of those messages. So those tend to have a smaller impact because wherever you are not making the healthy decision, the default decision, you're placing the burden of effort on the participant or on the end user. Where you're going to have the greatest impact is when you do make those default decisions, healthiest decisions, by changing the economic factors that determine them. So if you're talking about obesity, you cannot improve rates of obesity until you change the ability of people to make a living wage and have access to healthy foods because they are available to them in their neighborhoods. So you need to really look at issues of housing and poverty and redlining in communities. So socioeconomic factors that impact people's locus of control and people's ability to make those healthy decisions. The purple level, you'll see the change in the context to make individual default decisions healthy. These are laws that are put in place to make it easier, or policies that are put in place to make it easier to make healthy decisions. Above those are the blue, long-lasting protective interventions. So these are things that are, once you put them in place, they provide protection for a longer period of time. So you routinize, you normalize people's behaviors by saying, okay, everybody gets this vaccine, every fall, everybody gets a flu vaccine, and we make it free and we make it available at the drugstore and we advertise for it on television, and that will confer a degree of protection for the flu season that lasts the subsequent 6 months. And we normalize it and we make it just, have you gotten your flu vaccine? The first question that we ask people when they're making an appointment starting in September. The front desk folks are asking them those questions. So you institute some long-lasting protective interventions. And then above that is the green, the clinical interventions. So making sure that people are understanding how to control their diabetes, how to, test their blood sugar on a regular basis. Can we make insulin pumps more readily available and affordable, and teach people how to use them? All of these kind of clinical interventions, but then there's a big component of their success that depends on uptake and buy-in from the participant. So the impact is lower because it relies on effort, whereas things at the bottom of the pyramid are less reliant on individual effort. So at the end of chapter 1, she points out the IOM, the Institute of Medicine, and Robert Wood Johnson Foundation's joint statement on how to transform nursing that was released in 2011. Nurses should practice to the full extent of their education. They should achieve higher levels of education and training, that the doctoral degree is, the gold standard. Excuse me. That the education system for nurses needs to be improved. That we need to make it easier to progress to those higher levels of education and training, that nurses should be considered full partners with physicians and other healthcare professionals, that they are not the handmaidens that they have been typecast as of other clinicians, and that their role is unique, that the approach to clinical care of nurses is not the same approach as that of physicians, that our role is to promote nursing care, which is holistic care, which is wellness-based care, as opposed to medicine, which is much more focused on the problem and not on the solution. And then finally, that healthcare in the United States needs to be redesigned so that workforce planning and policy making is possible. So we need to engage our nurses in political platforms. We need to engage our nurses in opportunities for continuing education and continued progression through their clinical preparation, and those advanced practice roles, which are higher functioning roles because they're reliant on the intellect of the nurse and not necessarily the task fulfillment role of the nurse, which is really the role of lower functioning nursing responsibilities. So week 2, how do we identify and classify outcomes? So the chapter shows that outcomes can be classified by either who is measured, what outcome is being sought, or when an outcome needs to be completed. But she kind of leaves that proposal, that those are very classic ways to think about outcomes, looking at the population and really clearly defining that population, and looking at what outcomes are being sought. So what are the changes that we want to see in the population that we're studying, and when do we want to see those changes achieved? She sets these up as sort of, you can either do the who, what, and when of outcome measurement, or you can do the Donabedian framework, which I don't think that they are necessarily actually contrasting, that in fact they're complementary. I think Donabedian, if you know anything about him, he was really focused on putting the humanity back into quality assurance and looking at the ways that we have opportunities to improve quality for the delivery of services. He's really kind of the father of quality assurance. And his framework really proposes that the community as client be a way to reframe delivery of services, delivery of care, for example. And so he posits the measures of that care as either structure measures, process measures, or outcome measures. So how well is the infrastructure or the components of care in the community distributed? How broadly distributed and accessible are those actual structures? So clinics, dentists, hospitals, etc. Where are they, and how accessible are they? Process, meaning what are the processes by which we deliver care, and how well do they work, essentially. And then finally, outcomes. So are we able to track specific indicators that describe the progress towards the best outcome possible for the population that we're studying? So this kind of structure, or this diagram here, assessment of quality of care broken down into structure, process, and outcome measures. Some of the measures of structure that you would look at would be, staff. Do we have enough staff? Are they spaced, across the city, for example? Are there individuals with adequate preparation in those positions so that they can respond to the need that exists in that population? Do we have the equipment that we need? Do we have guidelines set up for how care is to be delivered and supplies? Process outcomes would be, what's the quality of the interaction people experience? How well are we asking the questions that we need to be asking? How well is health assessment and subsequent treatment, how well aligned are they? Are we doing adequate treatment based on the examination that's performed? And then counseling, are we adequately responding to people's needs, emotional needs, in the care that we're delivering? And then finally, outcome measures. These are the kind of bigger picture issues. Are we doing what we're saying we're doing? Are we doing what we're saying we're doing well? So morbidity, mortality, patient satisfaction, these are all end of the line. Like, did we do what we said we were going to do, on X measure? I love this quote from Donabedian. Ultimately, the secret of quality is love. If you have love, you can then work backward to monitor and improve the system. If we're talking about quality, really it is an expression of love and care, which is why it makes sense for us to frame the delivery of care in terms of quality, because really quality is not just about you delivering the service, but also how is that service received. So now is the challenging part of the lecture for me, because it means I have to navigate to a different screen, and I haven't been doing this very successfully, but we're going to try our best to make this work. So there are several, throughout chapter 2, I think that Curly does a really good job of showing or talking about these different websites and resources for examination of quality. And I just wanted to kind of navigate you to each of them and point out some of the high points of each, because I think that it will help you better understand the resources that are at your disposal. I actually, a lot of these I'm familiar with because I have them saved as bookmarks on my desktop for work. And I don't want to, how do I say this? I want to make it clear that I use these on a regular basis. That when I'm trying to, so for example, in my work, because I'm, health director, if we want to apply for funding, I need to make the case that there is a comparable program that we will base our application design on. I want to show that there is a need in the community based on characteristics of the population for that intervention. I want to show that the study design, or the design of the intervention that I'm proposing has been replicated in multiple other settings that are similar to my setting. So I need a comparable setting to compare it to. I would go to some of these. If I'm trying to develop, for example, we have a primary care grant from the Office of Minority Health, and we are promoting standardization of screening tools across our city so that providers are adhering to the U.S. Preventative Services Task Force screening guidelines and the early periodic screening, diagnosis, and treatment guidelines for children that are part of Medicaid requirements. So I'm putting these up as some relevant websites, but they really are relevant. They're really websites that I use on a regular basis, and they are great sources for you guys going into practice in primary care and psych mental health nursing. So the first is IHI, the Institute for Healthcare Improvement. They have a great distribution list newsletter, that you can sign up for to get regular updates from them about training opportunities, about funding opportunities, about new resources or white papers that have been developed. And rather than go back and forth between the presentation and the websites, I'm going to just head right to the next one, which is the Agency for Healthcare Research and Quality. ARC sets up tools that you can use to for clinicians and providers to kind of gauge how close are you to the gold standard, just to put it that way. The Cochrane Library, if you're ever looking to determine whether an intervention that you've heard about has been shown to be effective, the Cochrane Library is kind of gold standard of making those determinations. What is the status of obesity interventions? Is obesity intervention focused on walking, for example, effective and replicable? And can we scale it up effectively? This is where you would go you would search obesity interventions, for example. U.S. Preventive Services Task Force, as I mentioned, this is where you would look at your screening guidelines, and I'm sure you guys are familiar with this. It's probably touched on it with your health assessment course. The Early Periodic Screening, Diagnosis, and Treatment Program. So this is actually a site within HRSA, but Medicaid is the author of the EPSDT. But I think that I like this page because it puts it in context of the population that EPSDT is centered on and focused on. And you do have all of these kind of links to other ways that EPSDT is utilized. Okay, and so let's go back to the PowerPoint. So that's that page. And then additional outcome sources. So if you're looking for opportunities for outcomes to measure and track progress. So if you wanted to, for example, set up a pre and post intervention comparison, and you needed some data to make that case for the pre, and then another source, and then a source of data, comparison data. These would be some of the sources for indicators that you could use. So we're going to head over to the county health rankings, which if you put in your county, you can, I'll show you, for example, New Haven County, Connecticut. It will show you where we are, where we are generally, but then also gives you each of the indicators upon which that is focused. So if you're looking at specific indicators and need a comparison county to compare what's going on in Hartford County to New Haven County, and then look at what interventions are being utilized in each county to kind of make the case for why those counties should adopt each other's interventions. This is where you could go. Okay, I am going to go ahead and go through and show you some of the other sites that she mentions in the chapter. This is the National Highway Traffic Safety Administration, which is part of the U.S. Department of Transportation, the Fatality Analysis Reporting System. So if you are interested in looking at outcomes such as car crashes or pedestrian deaths or sleeping, how do we say that, like accidents that are impacted by texting or impacted by falling asleep at the wheel or those kinds of things, trucks and fatal accidents, buses and fatal accidents. This is where you could locate those data. Again, this is to look at indicators, and if you are interested in a specific intervention in your population of interest and you want to determine what's been tried, or what are the key indicators that you would use to track the quality of that intervention and how well it plays out the way it's intended, this would be a resource that you could use if you're focused on traffic safety. Likewise, the community guide is a resource that for 25 years has been focused on evidence-based decision making. This actually came out a few years before I graduated from nursing school, and so this was brand new when I went through my graduate program, and it's amazing to see how things have changed, but how much more attention has been given and allocated. And I think nurses now don't really have a sense of how much of nursing was sort of habit-based before the 1990s, that we just did things the way we did things because that was the way we had always done things, and that the advent of evidence-based practice and evidence-based nursing in particular is relatively new. And if you think about, like, when did Florence Nightingale first decide to throw open the curtains and let in fresh air and sterilize instruments by putting them outside in the sunshine and clean sheets of the Crimean War soldiers' beds on a regular basis, or focus on nutrition? All of those things that are seem very quality focused. It's really interesting going through public health school, having just finished nursing school, and my perspective was, Florence Nightingale invented nursing. Well, Florence Nightingale actually invented public health. Public health was then kind of co-opted by quality improvement and quality assurance efficiencies in the 1950s and 60s, when they were working on how to improve systems, or even if you think about 1920s when Ford was developing the conveyor belt and the system of assembling a machine the same way every time, because everybody has a certain piece to play or piece to assemble, and that there's a quality check at the end of that assembly line. For some reason, nursing kind of lost the focus on quality and kept the focus on repetitive actions, hoping that if you did it the same way, there would just always be a good outcome. And I don't think that necessarily started to ring true until they started to look at the quality piece of it, which had already been kind of adopted and adapted by industry. So it's just an interesting way that things have evolved over time. Okay, so Trust for America's Health is another website that I actually wasn't that familiar with until I read this chapter, but they do have different, they have different resources in terms of state data, health indicators, preparedness indicators, etc. So certainly go and check this out, this website. And then the National Neighborhood Indicators Partnership is also a really cool resource for looking into your neighborhood, your specific neighborhood, and interventions that have been shown to be successful. The National Nurse Quality Indicators Initiative is it's described in the in the chapter about how let's see, make sure that I'm not misstating this, but I was not that familiar with this. The National Database of Nursing Quality Indicators, this is on page 36 of the chapter, was created in 1998 by the ANA as part of the initiative to make changes to improve safety and quality of care, help educate nurses about measurement, and invest in research studies that examine safe and high-quality patient care. So it was originally housed by the University of Kansas Medical Center, and then moved to Press Ganey through a contractual agreement with the American Nurses Credentialing Center in 2014. So very interesting website that it is focused on, measuring quality and establishing nursing sensitive measures to look at that quality. And I'm going to just roll down to the indicators list. So these are some of the indicators that the NQI, National Database of Nursing Quality Indicators, uses to track 18 nursing sensitive quality measures to provide actionable insights based on structure, process, and outcome data. So you recognize those now: structure, process, outcome data. That's Donna Bedian. That these are specific measures that they will track for an entity. So if your hospital or your clinic wants to invest in this as a quality standard, it's, I think they mentioned that it's magnet recognized up here. It offers organizations the ability to submit quarterly data on nurse-sensitive quality indicators. Measures are in compliance with magnet, and healthcare organizations can utilize the benchmarked nursing satisfaction data to fulfill requirements of magnet recognition program. So it's essentially a tool that will help an entity get ready for magnet certification if that's what they're going for. But I for our purposes, I think it's interesting that it's resulted in happier nurses. Job enjoyment increased by 25% in 2 years among 25% of the participants. Intent to stay increased by almost 30%, and quality of care increased by 5 to 20% in 2 years. So this is a picture of what their dashboard looks like. And these are some of the entities that have signed on and utilized it. You can see a lot of them are international entities. It looks like in the Middle East. So I'm just curious, where the uptake is in the United States, because it seems like a useful tool to help those clinical entities get ready for magnet certification. Okay, let's keep navigating through, and another resource is the National Database of Nursing Quality Indicators. We already talked about that. We talked about ARC. Healthy People 2030. I think you guys are all familiar with Healthy People 2010, 2020, 2030. That The 2030 indicators have been changed and updated to have much more of a focus on health equity is really encouraging. And then I also wanted to point out that the Office of Minority Health, let's navigate over there. Office of Minority Health, in addition to just being awesome in terms of resources, clinical resources on cultural competency and funding that they do, they have briefs and publications on specific policy agendas, and they have data resources. But the Office of Minority Health Resource Center is also a great resource for funding. So if you guys have, you want to do something in your clinical setting to implement an evidence-based project, you can ask for assistance from the National Office of Minority Health Resource Center. It's a separate office within the OMH, and they will give you hands-on assistance finding funding for that specific topic. So, for example, you observe that a lot of the mothers that are coming in are not, how do I say this? Maybe they're not finding childcare, and they're having difficulty finding childcare, and you want to propose some kind of solution so that moms in your community can have a better understanding of the childcare options available in that neighborhood through some kind of information technology. So you can submit a funding search request, and their team of librarians will actually, start searching for funding related to that for you, and or assist you with the data that you would need to develop a proposal for a grant for that. And I've, when I worked at the state of Texas, availed of this several times, so I know it's not just, a fantasy. So just wanted to point that out to you guys. And then National Quality Forum is another resource. This is a great way for you to identify some of the healthcare issues that are really priority for nurses in your practice area, and connect to other folks who are working on these same issues. I know we're getting long on time, so I don't want to belabor these, but I am going to make these slides available to you. The Leapfrog group, I'm sure that you're familiar with Leapfrog, but if you're not, Leapfrog is a national quality program that focuses on identifying quality indicators for hospitals and then making those assessments public. So what do we know about quality assurance? One of the very valuable components of quality assurance that makes it most effective is the public nature of it. That if you you do an audit of your practice and then you don't share the results, there's no accountability to that. Entities like Leapfrog, National Quality Forum, other national quality databases make those results public so that there's pressure on the entity to maintain quality and to really make their really sustain the quality processes that they have put in place. So it's like applying for magnet certification. There's nothing that requires anybody to be a magnet facility, but if you are a magnet facility, it shows that you have done a voluntary self-examination, and that self-examination has been verified by an external entity to really quantify the measures that show that you are delivering quality care. the entities that have gone for magnet certification then have higher quality ratings, which generates income for the entity. So a hospital that has magnet recognition is, by virtue of having voluntarily gone through that auditing process, making more money. And that's an incentive. It's a huge incentive to maintain that quality. Where you run into trouble, of course, is when people are not transparent in that process. But it is certainly a valuable process that we've gotten used to seeing, but that is relatively new. Okay, so we talked through this already. Skip. So in general, in summary, the role of the APRN is critical in the delivery of population-based care. What does the APRN have to do to deliver quality care? Know the population, be able to describe the population, determine what are some relevant outcomes for that population's health to improve, select evidence-based structure, process, and outcome measures to track improvements, compare the measures to national norms or trends, track patterns of quality, allow the data to speak for itself, and always center health equity and advocate from your experience. That our role as advocates to promote health in the larger, larger conversations around health, whether that be through legislative processes or through changing policies at your healthcare institution, or even, at the even basic levels in your community, getting involved with a school health advisory committee, for example, to make sure that the quality of care that's being delivered to students in a school district is according to the best practices or according to evidence. These are all critical ways that we can continue to elevate our practice and expand our scope of influence. I really liked the last kind of few paragraphs in that chapter. APRNs have successfully tested interventions to decrease health disparities, and by careful and thorough review of current literature and resources available, they have the tools to develop additional effective and culturally sensitive interventions and to identify outcomes in order to achieve better and more equitable health outcomes. All right, everybody. So that's the end of today's lecture. I'm going to try and post this and make sure that it recorded the way I intended it to. In case the links didn't work, I am posting both the slides and the recording so that you can access the slides independently and navigate to each of those websites by yourselves. If it didn't work, just in case the navigation to those external websites didn't work during the PowerPoint. If they didn't, I apologize. I'm really a tech savvy person, but for some reason, the technology around presenting live doesn't always agree with me. Okay, have a great Memorial Day, and hope you guys get to relax a little bit with your family and friends. And the next lecture will be posted week after next to cover chapters 3 and 4. This will be kind of digging into the epidemiology content that's in the next couple of chapters. Take care.